Hello everyone, Dr. Kimball here. Today I'm going to talk to you about number 6 in our 7-part series, how to fix or heal your bulging disc. If you've followed with me so far, I haven't gotten a lot into surgical intervention, so today the big focus is going to be on microdiscectomy and how that can help you to heal or fix your bulging disc. You would only consider surgery if you're not getting better with the other therapies that I've discussed. If you're having persistent intractable pain, weakness, numbness, and dysfunction, then you and your surgeon might consider doing this surgery. Let me first tell you that microdiscectomy, in my experience, is best entertained when your symptoms are primarily related to leg pain or sciatic pain. If your biggest problem is low back pain, then you may have a bulging disc, but that bulging disc will typically cause pain in the back and not just the leg. A herniated disc, when it's pushing on a nerve, is really it's the same problem, but it's a secondary problem. And the secondary problem is the nerve impingement. So this procedure is geared at reducing the compression, taking away the compression off of a nerve that is irritated and having lots of problems. So you can't expect that this surgery is going to fix or heal your disc. It's not going to do that. It's not intended to do that, and you should never expect that it will. When the surgery is performed, a small incision is made on the back, and I work personally through a small tubular retractor. It's about the diameter of a dime, 18 millimeters, and we work through a little minimally invasive tubular retractor. We use a microscope and try not to disrupt the soft tissue. That tube is placed over the spine, right where the nerve is. We use X-ray to guide placement of that tube. And then through that tube and using the microscope and some special instruments, a little bit of bone is shaved off the spine, giving access to the nerve. Once the nerve is found, it is gently teased over, and underneath it is where the herniating disc is found. When you find that disc, oftentimes a small incision is made in a layer of tissue that is containing it, and then that disc has the chance to come out with a little bit of help from the surgeon. Sometimes it comes out in one large piece, sometimes it comes out in a bunch of little tiny pieces. After that disc herniation is removed, the nerve is no longer compressed. Usually the surgeon will then go and look around for any other soft fragments within the disc space that are free floating and ready to follow at another time. You see, what we don't want to happen and what you don't want to happen is to have a disc reherniation. That's really one of the most discomforting and tragic things that happens with this surgery, and it can happen up to 10% of the time. So after the surgery, you might be doing well, and then in a delayed fashion, you could push out more disc. Now remember, your surgeon might have had to make a small incision in the disc annulus or that little layer. The annulus may have already been fully torn, and in that case, you wouldn't have to do that, but it's weak, and there is the risk for more disc to come out. You have to understand that this surgery is geared at fixing a secondary problem from the herniation. It is not geared and it is not meant to just fix back pain, although you may have back pain from your nerve compression. You may have back pain from the disc degeneration that's occurred by the herniation. Those can come together. When the disc herniation is removed, you may feel, and most likely will feel, improvement in your leg pain and the symptoms in your leg. You may also have significant improvement in your low back symptoms. That's a big win. But what I would tell you is that you shouldn't expect that it will go away completely, and you should also understand the problem, the failure internally to the disc hasn't changed. It is still a torn, fractured, or an injured disc, and that primary problem is still there. So I like to remind all of my patients that, listen, this surgery, although it's minimally invasive and only takes 45 minutes and you get to go home a couple hours later and you're going to be feeling better right away, this is not a fix. This is not a fix for your disc. It is a fix for the nerve, and that's what it's geared at. There are risks associated with the surgery, but it's quite common, and in good hands, you can expect to not have any major complications. What I would be most concerned about as a surgeon would be having a reherniation. There is one technique that is rarely performed. It's called an annular closure. If you've been following along and you know what the annulus is, you're ahead of most people. The annulus is the outer layer of the disc, that fabric, kind of crisscrossed, where the tear in the disc occurs. That's the outer layer that typically will hold the disc into place. Now, once the disc has herniated, that area has torn, your surgeon can, if he's capable and experienced in doing so, he can actually suture that closed. That can help reduce the risk of a reherniation. So that's a big win. I perform that in my patients when it's safe and possible, and when the tear in the annulus is appropriate to repair it. That can be done through the same minimally invasive incision. It takes a bit of experience and a little know-how to do it safely, but it's definitely possible to be done, and it, in my experience, does reduce the risk of reherniation. Additionally, this procedure, annular closure, can be performed with some stem cell type of procedure at the same time to facilitate healing of that annulus at the same time. And I can go into that at another a video in the future. So, in closure today, I know this video is getting a little bit lengthy. I just want to let you know that the process of microdiscectomy isn't a fix for the disc, it's a fix for the nerve. Thanks so much.